Hello, and welcome to the 4th Annual Federal Research Update webinar. My name is Dr. Heather Brown, and as Director of Grant Writing and Publications at the University of Missouri-Columbia, I am so pleased to welcome you to our event today. Our webinar is sponsored by the University of Missouri-Columbia, the National Association of College and University Business Officers, and the Florida High-Tech Corridor Council, an economic development initiative of the State University System of Florida. Today, while you're watching our webinar, if you have any technological problems or questions, please send an email to federalupdate@missouri.edu. And if you have a question you'd like one of our presenters to answer, please send it to federalupdate@missouri.edu, and you can send those questions at any time. Just for everyone who's listening, want you to know that after our event is over, the slides of our presenters will be available on the website where you registered to view the webinar, and in a couple of weeks we'll also have the edited video uploaded so that you can go ahead and watch those over again, or for the first time if you for some reason were unable to see a particular speaker at a particular time. Today I am very pleased and honored to introduce Dr. Carolyn Clancy. Dr. Clancy is the Director of the Agency for Healthcare Research and Quality. She holds an academic appointment at the George Washington University School of Medicine and serves as Senior Associate Editor for the journal Health Services Research. As Director, she launched the first annual report to Congress on healthcare disparities and healthcare quality. Over to Dr. Clancy.
Thank you so much. Good afternoon from the East Coast, and good morning to those of you in time zones west of here. I'm really excited to have the opportunity to talk to you today about the Agency for Healthcare Research and Quality, or as we call it, AHRQ. Now, AHRQ is part of Health and Human Services, an operating division, a separate component from, say, the National Institutes of Health or the Centers for Disease Control and Prevention. And AHRQ is just a little over 20 years old and was initially created by the U.S. Congress in response to mounting evidence about variations in healthcare spending and healthcare quality. And at that time, this was a very new field of inquiry, and the researchers doing the work were actually able to make it very clear to policymakers that in some parts of the country, they were spending much, much more, for example, on Medicare than they were in other parts of the country, and yet they weren't the people where they were spending more weren't necessarily getting better care or better outcomes. Hence, they created a research agency with two purposes in mind. One was to fund research that matters to healthcare right now. The second was to figure out, working with those who deliver care, receive care, pay for it, and so forth, how it is that we could accelerate the application of that knowledge to improve patient care. So we find our work incredibly exciting, and I hope I can convey some of that to you during this time. So I'm going to start with a slide about health system transformation, which doesn't necessarily jive with what you might have been thinking about research grants and funding opportunities, but I will get there. Today, I think there is no debate that our current system, the quality is variable. It's incredibly expensive. We lead the world in how much we spend, and it's often wasteful. And the future that we're anticipating is one where no matter where you land for care, you get care that is seamless, high quality, and affordable. Some of the problems that we see in quality are actually related to how we pay for care. It's something of an ancient system, at least as measured in multiple decades, where we pay by the piece, if you will, fee for service for the most part, which means that we tend to pay, especially physicians, if they do more stuff rather than if they do the right stuff. So there's a lot of work going on now to try to figure out how is it that we might change reimbursement or enhance it or modify it in such a way that we would be rewarding excellence in care itself. We also pay for transactions. Any of you or who yourselves or have had family members or friends dealing with a moderately serious healthcare problem will know there's a whole array of transactions, but what's really of great interest to individuals and their caregivers and those who care a great deal about them, is what happens over an episode of care. If I get a knee replacement, for example, can I go back to playing golf or whatever it is that I found very exciting and fulfilling? Will I be able to work? Can I walk to get the bus? That's what I mean by episodes of care. And there's a huge amount of interest, initially led by those in the private sector who pay for care, but now extending to larger segments of the public in knowing how good is the quality. How safe is this hospital? How likely is it if my dad is hospitalized there that he will get an infection? Right now, most of those assessments are based on process. Did we give you the right medication? Did we do the right test? Ultimately, what we're going to be focusing on is outcomes or end results. So that's Healthcare 101 in one single slide. But that is the context in which we fund research. Now, what's very clear is that maintaining the status quo is not an option. You know, historically, we have assumed that if we had incredibly well-trained healthcare professionals in great facilities, and of course we fund lots and lots of biomedical science, that somehow this would all trickle down to the point of care and magically people would get precisely the right treatment at the right time every time. And it's only since we've learned that does not always magically happen that we've realized that yes, evidence continues to be produced at a very rapid rate, but its incorporation into clinical practice is much more leisurely than that. In fact, a study we funded found that on average it takes 17 years for 14% of funded research to benefit patients. Now, I have no idea if 14% is a good number or not such a great number. 17 years, way too long. We can do a whole lot better than that. Hence, that was a big part of why AHRQ was created. Now, the buzzword these days is transparency. We see reports and report cards and websites and all kinds of information everywhere, and boy, is it hard to sort through. And that's why I say that what we're doing in terms of transparency hasn't yet consistently translated to meaningful information. And sometimes the patient is something of an afterthought. Not for any lack of good intentions. It's just that healthcare is increasingly complex, and it can be hard to remember the unique individual whose needs and preferences we are here to address. Now, we've got lots of vision, but it's incredibly clear, as illustrated by this quote from Stephen Sondheim, that everything depends on execution. A vision is not the same thing as a solution. To say it a different way, health research does not lead to better care unless it is tightly linked with strategies to make sure that that happens. That's the kind of research business that we're in. And so from here, I'm going to talk to you about AHRQ. And I'm going to be talking very specifically about those reports that we submit to the Congress every year on quality and disparities. I'm then going to shift gears to talk about 21st century care. How do we get to care that is safer and better? Where does research fit in? And then talk about applying the science to patient-centered care. So, AHRQ at a glance. I hope by the end of this you'll be completely persuaded that I would be happy to stay with you till midnight telling you why the work we do is so exciting. I won't. For one thing, you might need a bio break or to get back to your real lives. So this is our best effort to distill the high priority items into one slide. Ever since the Institute of Medicine funded their study on To Err Is Human, which made it clear that between 44,000 and 98,000 people die every year as a result of the care they get, not intended, not the disease. This is as a result of the care. We've been given quite a few resources from the U.S. Congress to focus on efforts to make care safer. This is a program where we fund grants, we fund contracts, and sometimes we fund training programs to create tools and strategies to help people. Big focus on hospitals. But at the same time, in recent years, we've also been moving to ambulatory settings because increasingly much of healthcare is being delivered beyond the hospital walls. Our effective healthcare program is research that focuses on which treatments work for which patients and under what circumstances, and what's the best strategy and approach to make sure that the right treatments get to the right patients. Sometimes this is called comparative effectiveness research or patient-centered outcomes research. I think of it as precision medicine. Now, precision medicine to me means that when clinicians and patients are in the luxurious spot of contemplating an array of options for treatment, diagnosis, that they have a good idea of a starting point because we have given them good comparative information. Harder than you might think, and right now, very, very little good information in that regard. We also make a huge array of data available for researchers as a platform for assessing quality and so forth, and we provide scientific support to the Preventive Services Task Force that makes recommendations about preventive service recommendations like cancer screenings, which kinds of counseling works, and so forth. And I should say that about half of the money that we invest in patient safety focuses very explicitly on healthcare-associated infections. Now, every year we report to the Congress on the state of healthcare quality and the state of healthcare disparities. So the good news is that we've been doing this since 2003. It's required by law. And overall, every single year, we've seen statistically significant improvements in care across all settings in all populations. So that's really good news. The slightly less good news is the magnitude of that improvement is considerably less than the regular increase we see in the rate of spending. Even in the past couple of years, where the annual rate of spending has declined a bit, costs are still going up, but not nearly as rapidly as they had been just a few years back. Even in those years, the rate of quality improvement is slower than how fast costs are rising. And disparities in quality remain pervasive and somewhat resistant to change, but not entirely resistant to change. And we see huge variations in quality of care. Across types of care, across parts of the country, even within the same institution. Now, this is a very complicated slide, but actually the colors make it very, very easy. So the rate of change between the 2012 report and the year before was just about 2.5%. Now, that's across all kinds of different types of measures, different types of care. So nearly 60% of the quality measures actually improved, which is a good thing. And the color code to this graph is pretty simple. The black part of the graph is where things are getting better. The blue part is where things are about the same, and that kind of funky green, maybe chartreuse, is where things are actually headed in the wrong direction. So this particular slide is just looking at the total over on the far left for all Americans, and then compares and looks at different population groups. So the second bar from the left looks at the elderly, 65 and older. By the way, I think elderly is a designation that keeps increasing in my own personal worldview. I'm ready to put the age up to maybe 80 or so. And then the third one compares African Americans with Caucasians and so forth. But you get the picture that the patterns are different depending on the population group. Now, disparities, again, keeping that same color code in mind, we see much slower improvement in disparities, but very, very importantly, we do see some improvements. So if you look again at the black portions of this graph where things are improving, you can see that we are seeing some improvements. And because we're tracking the same metrics over time, we know that this is possible, and we know that as this country becomes more diverse demographically, that we really have to accelerate progress here. Now, the reaction to most national reports is pretty straightforward. The first reaction is something like, oh, really? I thought we were doing much better than that. The second reaction is, Well, I wonder who those yahoos are who are dragging the average down, because we're doing a great job here. So this is another way of saying that for data to be meaningful, it's got to be pretty local. So in addition to national reports, we also create a web-based tool which is state snapshots. Now, any of you who've ever had the painful experience of being tortured by slides of spreadsheets with very, very small fonts looking at how we're doing in quality may appreciate our effort to make this a little bit more visually compelling for policymakers. This is a speedometer. Since I'm sitting in the District of Columbia today, I thought I would just show you how DC looks, right in the middle of the average range, the solid arrow being where they are now. In the most recent year, the dotted arrow is the year before. So it's average, but it's pretty stable. Now, what we find in every single state, and I would dare say probably every community and every institution within those communities, is areas where the state, or in this case the district, are doing well, areas where they're about average, and areas where they're worse than average. Our point is not to create the ultimate report card, but actually to distill the information from the data for policymakers in a way that's more understandable. So in DC, women between 50 and 74 who received a mammogram within the last 2 years, that's better than average. Adults whose doctors sometimes or never listened carefully, explained things clearly, or respected what they had to say, who are enrolled in Medicare and Medicaid. This comes from a survey developed by researchers funded by AHRQ. DC is about average. And patients having surgery who received recommended practices is worse than average. So policymakers in the district could use these findings to learn what states and localities are actually doing better in, say, surgery patients receiving recommended practices, so that they could learn from that. Now, the Affordable Care Act has gotten a great deal of coverage and public discussion, but one of the best kept secrets is that a huge percentage of the total number of pages, and there's quite a few, actually focus on improving quality and care delivery. And in fact, right in the middle of all these provisions, there is a requirement that the Secretary of Health and Human Services deliver to the Congress a national strategy for quality. Now, for those of you who've ever been confused about quality websites or having a hard time figuring out how to use that information for the decisions or questions that you have, you might think that strategy would be exactly what we need, or that we haven't had one. You might be right. Because healthcare in this country, the vast, vast majority of it is actually delivered in the private sector, we recognize that responding to this directive meant a very strong collaboration between the public and private sectors. So these are the very high, broad aims of this strategy. Better care. Wherever you land for care, you know that care is going to be excellent. You know, several years ago, I had the poor judgment to get sick on vacation and need to go to a very tiny, I guess what might be called a rural hospital. And suddenly the notion of better care wherever you land took on new meaning. I will say they did a fantastic job, thankfully enough. Better health. At the end of the day, we make huge investments in healthcare because we think we're going to be better off as a people. And public health and community-based activities and interventions have a huge role to play here. And this is not to suggest that the healthcare sector should take that over, but that the healthcare delivery sector can be a very strong partner. This is particularly important because the big ticket items now for healthcare, for research that matters, are all about improving care for chronic illnesses. In part because of the success we've seen in treating many, many diseases, thanks to our investments in biomedical innovation, mean that we get to live longer, to have those multiple chronic diseases, but that's where we're not doing so well. So better care, better health, and care that is affordable. And by affordable here, I don't mean cutting services or benefits. What this refers to is actually getting to more efficient care by identifying opportunities to remove waste from the system and to change how we deliver care so that it's much more centered on patients and that it's far less wasteful. Now, this doesn't mean, this national strategy, that we can start all over again. In fact, there's a lot of activity going on in quality in the Medicare program with private insurers and so forth. So what we did in collaboration with many, many partners was to come up with a focus on 6 priorities. Right at the top of the list on this slide you can see is patient safety. Making care safer by reducing harm caused by the delivery of care. Several speak to ensuring that people and their families are engaged as actual partners in their care, that we've got good communication and coordination. Notice how these words roll right off my tongue. Research that can help us clarify how to do that effectively and to do it effectively every time. That's a big ticket item for us. There's a huge effort now to try to do as good as we know. And by that I mean this 4th bullet here, promoting the most effective prevention and treatment practices for leading causes of mortality, starting with cardiovascular disease, actually speaks very directly to efforts to take what we know about treating the most common risk factors for heart disease and stroke and doing it routinely and reliably. We've known for over 40 years that treating high blood pressure matters. Not because one number is better than another, but because it prevents strokes, it prevents premature death, it prevents heart disease, and so forth. And yet just about half of Americans who with high blood pressure have good control. And I think the rest is fairly self-evident. So that's, again, a very strong focus on context, but it is a strong focus of the research that we fund. So shifting gears to get to care that is safer and better. I mentioned that we focus on work in patient-centered outcomes research or effective healthcare. And our authority actually directs us to make the information available to multiple audiences in a way that's tailored for their needs. Now, most researchers, in fact, I would say all health researchers, are passionate about making a difference in people's lives. This is what makes them work weekends. This is what inspires them when it feels like everything in the world that could go wrong has gone wrong, and then some. But that passion is not the same thing as the skill set needed to communicate to people with different levels of understanding and health literacy and so forth. So we actually support a center at Baylor in Texas that has expertise in communication and clinical decision sciences. I sometimes ask audiences which of these types of products they think is the shortest. Since I can't see you today, I will simply tell you that it's policymakers. And given the breadth of issues that they have to know about, it's got to be very, very focused and to the point. But the issue of how you communicate research findings to different audiences is, again, a big part of the work that we support. The consumer guides have made me personally wildly popular with friends, relatives, and so forth. And one of the things that we're learning is that journal publications in peer-reviewed journals and so forth are incredibly important for building science. There are very few single blockbuster studies, definitive, this changes everything. They happen, but not all that often. More often, science is incremental business. And so the peer-reviewed literature is a very, very important part of that. It is not actually the most effective way to get information to people in practice, people working on the front lines of care, to patients and families. So we will stop at nothing, because this is a big part of the charge to my agency from the Congress, to try to get information to people where they are. So that means that we work with medical professional organizations, for example. We make information available for faculty slides, presentations, continuing education, which I know a lot of your universities do. And sometimes we even have things like announcements in supermarkets. So listen the next time you're at the supermarket. You might hear a public service announcement from us. This next slide just gives you a sense of the recently released translation products. So I hope that you're getting a sense of, these are not prescriptive. They are very much about, here are the facts. Sometimes a report will say more or less that there are new procedures currently emerging, but we don't have enough good evidence to say very much about them at this time. But it gives people a clear sense of what they're working with. And the second sense I hope you're getting is that how the results are communicated is incredibly important to us. In fact, one of the guiding principles at our agency is something called the Porter question. The Porter question was named for a former member of Congress. And he was chair of the subcommittee on House Appropriations that actually figured out the budgets for all of the research components of Health and Human Services and other parts of the government. So he was well known in the health research community. And one year he asked all of the heads of these agencies, what impact is your work having? And when my predecessor said, we're publishing in peer-reviewed journals and more and more faculty, and it's a bigger part of academic institutions, he said, that's wonderful. And that's not exactly what I meant. What I meant is, what effect is it having on people? So that is a real touchstone for us, and it is a very clear criterion for the kinds of research that we fund. Now, our authority in this patient-centered outcomes research actually does not come from the Affordable Care Act. It predates it by about 7 years, and it comes from the Medicare Prescription Drug Improvement and Modernization Act, sometimes referred to in shorthand as the Medicare Drug Bill. And interestingly, what it says is, the middle section here, number 2, conduct and support research, we know how to do that. That's our day job. The first part says that researchers don't set the priorities by themselves. So for those of you who come from institutions that include a healthcare delivery component, whether that's clinics or a hospital, or you're affiliated with institutions like that, what this means is that setting the priorities for the research involves people involved in the actual business of providing health care. And the third part I mentioned a moment ago says that assure that the findings are accessible and understandable by multiple audiences. And very importantly, Medicare and Medicaid cannot use these findings to deny care. What we're trying to get to is not please don't do something, but actually figuring out which treatments work for which patients and so forth. One of the other things that we've learned is, and have actually made some investments in, is better methods to prioritize future research needs. Now, it is absolutely impossible in America, and I would guess in other countries as well, although I don't happen to be fluent in other spoken languages, to read a research study that doesn't have a section at the end that says future research should address. Now, that's often incredibly important and interesting, but it's also often subjective. So we actually came up with a method and invested in teams of researchers to come up with methods to identify and prioritize future research needs based on both scientific gaps and a very clear scientific process for identifying those gaps, as well as hearing from people who are leading healthcare organizations, from patients, families, from clinicians, and so forth. So stakeholder involvement is an essential part of this process. And in fact, I recently heard stakeholder engagement described as the blockbuster drug in the 21st century. Right? We have made this assumption for so long that all research will automatically benefit and lead to better care, that now what we're trying to do is make sure that we make research investments, at least at AHRQ, based on what people identify as the main questions that they'd like to see addressed. Now, the Affordable Care Act creates a new private sector institute that funds this kind of work. It's called the Patient-Centered Outcomes Research Institute, which is funded by the Patient-Centered Outcomes Research Trust Fund. 80% of that trust fund goes to this new entity called PCORI, and again, it is its URL is at the bottom of the page here. So they have regular funding announcements as well that your researchers may want to be attentive to, and very importantly, they do not come out in federal publications because they are not a federal entity. So their website happens to be very, very important. And they've got a fair amount of resources to invest. 20% of that trust fund allocation, though, comes to AHRQ to support building capacity for this research, by which I mean a variety of individual and program training grants, very similar to NIH mechanisms, as well as activities and dissemination, including research on how do we get information to the point of care in a way that makes it very easy for those on the front lines of care. And we don't just focus on clinical interventions. This execution part, I said very blithely, you know, at 10,000 feet, we're interested, policymakers are interested in changing payments so that we reward quality. So the question is, how do you do that? And what we have commissioned and supported are a series of reports that give us what evidence exists now about different payment strategies, about interventions to reduce health disparities, what we know about helping patients adhere to recommended treatments, and so forth. Now, the big thing, or the new thing, as people sometimes say, in healthcare is health information technology. And I'll bet a number of you are either groaning through this implementation right now at your own institutions, or you've personally had the experience that I've had of going to an emergency room and seeing signs everywhere that say, "We thank our patients for their patience. We have a new electronic health record." But ultimately, this health information technology provides a platform both for discovery as well as for rapid application of science to improve care, which is incredibly exciting. It gives us an opportunity to accelerate our efforts to improve quality in a big way, and it makes it very easy to collect information systematically on patients with similar conditions. So, for example, we have funded and provided support to the American College of Surgeons for a number of years to collect information from all patients having major surgical procedures so that they can actually understand the relationship between process of care and outcomes of care. And they have seen, as a result of these efforts, mortality from surgical procedures go from extremely low to almost infinitesimal. And we actually fund a lot of research on the use of health IT to improve safety and quality. We know it can give clinicians real-time access to the information that they need and to help to make the best possible decisions with their patients. And it can actually help patients become more involved in their own care as well. Ultimately, what it's going to mean for people providing care is that it will change the development of knowledge. It will change the metaphor from one of hunting to one of farming. What I mean by that is, if I'm seeing a patient right now, or later this afternoon, say, and I have a question, what I do is excuse myself extremely diplomatically and rush over to a computer terminal and Google. And sometimes that works like a charm, and I've got an answer in 10 seconds, and other times it's not that easy at all, and I have a hard time finding what I need. That's what I mean by the hunting. But now we will be able to use this technology to learn as a byproduct of all the data we collect in healthcare all the time, every day. Health IT, this is just an example from some funded work by AHRQ, can also be used to improve the implementation of evidence-based prevention. This was an interactive preventive health record funded in and examined in 14 primary care practices. And again, getting back to the execution piece, it's not just, wow, an electronic health record, that sounds like a great idea. It's also, how does it fit into the workflow so that it's easy and people are likely to use it? Now, one of the big, strong focus areas for policy in health information technology is often referred to as interoperability. And if that suddenly conjures up image of lots and lots of technical meetings, you'd be exactly right. But the point of all this is, in a care system with multiple separate parts, most of which are not necessarily linked together, you've got hospitals and practices and ambulatory surgery and urgent care centers and walk-in clinics and the like, it can be very, very difficult, absent a strategy, to figure out how patients' information can follow them wherever they go. This makes me very worried for everyone I'm related to, because they seem to all believe with a clear passion about it that their information seamlessly follows them no matter where they land. But this health information exchange, which is what this functionality is sometimes referred to, can be used not just to show that we can move electrons around, but that we can actually use it as a platform for research. So what this slide describes is a program in Indianapolis where 6 hospitals working together to improve patient safety were actually able to reduce the rate of those deadly methicillin-resistant staph infections by 2/3. And the reason they could do this was any time a patient showed up at the emergency room, they immediately queried the state lab to see, was this patient infected in the past year? Did they have a positive culture? And if they were immediately isolated. That's the power of health information technology. And indeed, this same kind of technology is going to make it possible to create research networks that we could only imagine in the past. As part of our investments with the Recovery Act in patient-centered outcomes research, we actually funded a number of efforts across the country. Some of them are patient registries, some of them are networks and collaborations between academic centers and community partners that address all kinds of different populations. Again, trying to take advantage of the care generated when providing care for learning and also for improvement. And there's a journal supplement that talks about analytic methods and so forth. Now, you know, at the end of the day, healthcare is very personal. So one of the ways that people learn about healthcare is actually through stories. Certainly, lots and lots of people learn very important medical information from watching Dr. House or other kinds of medical TV shows and so forth. On our website, for those of you who are involved in the health communications business, there's a video novella that helps patients, it's in Spanish, compare diabetes treatments. Now, one application of information about quality of care is actually the measurement of quality. In our reports to the Congress, we draw from the best possible measures and work with all of our partners across Health and Human Services, but we also develop some measures. We don't collect the data for that, but we are the science partner to these efforts. So 3 areas where we actually do support the development of measures. One are a family of surveys that ask patients about their perspectives and experience of care. So on that, the unexpected hospitalization when I was on vacation, when I got home a couple of days after being discharged, I had my own survey waiting for me in the mail, which was quite interesting. This is not, do patients like the carpeting and so forth. It's all about, or the food. We usually know the answer to that question. But it's all about, did people explain things clearly to you? Did you understand what was happening when you were discharged and what you needed to do next? Did people treat you with respect? If you had pain, were people attentive to your needs and so forth? We also make available measures for use by a variety of entities, quality indicators, common formats, or common definitions for assessing patient safety events. And one of the areas where we've just funded 17 grants and we're very, very excited is what we're calling the science of public reporting. Again, this gets back to the importance of communication and tailoring that communication for multiple audiences. A couple of times I've mentioned websites that might not be as meaningful as we'd like. This is an effort to try to grow the evidence base to inform the content design, dissemination of the underlying data and methodology of public reports so that they are as useful as possible to a variety of populations. We make a portal available on how we can integrate behavioral health and primary care. For far too long, these aspects of healthcare, even though the mind and the body generally tend to coincide in a single individual, they have been sort of separate systems of care. Those days are behind us. And we also make available software for people to create their own websites and so forth. Now, one very exciting development that I think a number of you may be seeing or hearing about at your own institutions is simulation. So at its simplest, instead of knowing somewhere and pretending not to know, that every medical student had to start somewhere. So sooner or later there was a patient number one, and that might be you. The new way of thinking about education, training, and not just learning the first time, but learning when new techniques and new technologies become available for procedures and so forth, is called simulation. So people spend time in a laboratory learning on sometimes fairly elaborate computerized models. It is also a fabulous platform for learning about how to work together effectively in teams. So what that means is that when people do procedures for the first time, and a procedure can be anything from drawing blood to literally performing surgery, they've practiced several times under supervision. It's a risk-free environment for learning, and they can get immediate and realistic feedback. So we're funding a fair amount of work in our patient safety portfolio focused on how this technology can best be used. And I'm seeing this in many medical centers across the country, and sometimes used as a way to support interprofessional training. So applying this science to patient-centered care. One of the ways that we try to get out good information is to create toolkits. So one really vexing challenge for healthcare is something called medication reconciliation. This is not marriage counseling or in any way preventing divorces among medications. What it means in practical terms is, again, because there's more and more people with chronic illnesses, people are admitted to the hospital and they've got one list of medicines that they're taking. Some of their medicines may be changed as a result of the care they got in the hospital. When they are discharged, they go home with a new set, and if we're not careful, they may either double up or take things that interact in a way that could harm them, and so forth. So we made and worked very closely with hospitals to test and make this useful, a toolkit to make this easier to do at the time of discharge, or either discharge home or to another setting. We've also worked with health plans, as shown in this slide, to actually promote the idea that patients should be asking questions of their care, and there are some fantastic videos in our website for that. And we're studying, as I said, different models of delivering care. So both the clinical content, but also the environment in which that care is provided. One very important new development in the world of primary care, which has been really quite a revitalizing force, is something called the patient-centered medical home. Now, if you think about that, you'd have to imagine that really great primary care, what it looks like, is probably going to be different in downtown DC than it's going to be in rural Nebraska, and possibly different still from what it would look like along the border in the southern parts of the country or in other frontier areas. So again, the focus here is not prescriptive, but science that informs such questions as which models are most effective, what type of setting, what type of patients. How is it? A big part of the patient-centered medical home is the notion of connectivity and linkages between care delivery and community resources, trying to figure out how do you do that? What's the evidence for that? How do you do it effectively? There's also a very strong focus on patients being involved as active partners in their care. Well, that sounds like a great idea. How do I do that? How does a patient do that? How do we support them doing that? Where does health IT fit in, and so forth? We also support an entity called patient safety organizations. These are organizations where providers, hospitals, doctors, anyone can work together in a safe place to examine medical errors and interventions to reduce medical errors without worrying that that information is discoverable. No one loses the rights that they have to sue right now, but what it does mean is that any additional information can't be used to punish people or used against them in a court of law. And we're working very closely with the Uniformed Services University of the Health Sciences here in a graduate level course called Patient Safety and Quality in an IT-driven world. When I think about the new skills and competencies we're going to need to get to this healthcare system of the future, it's very, very clear that all healthcare professionals are going to need to have a considerable degree of literacy in the use of data and data analytic methods and applying those in care on a routine basis. And we're also going to need to be training experts as well. And we also make available for clinicians a wide array of information. What I'm showing you here is done on behalf of the Preventive Services Task Force, and it's completely unreadable even for me, so please don't look at the fine print, but it is on our website. And this is how clinicians can talk with their patients about screening for prostate cancer. Again, thinking about the execution path, based on research that we've supported, we've also made available guides to help independent pharmacies implement electronic prescribing by focusing on the hurdles and problems that can arise and strategies to address those. Same for small practices. So where do we go from here? Those of you who read The New Yorker or are fans of a surgeon named Atul Gawande may have read a recent article published in mid-August called Big Med. And the metaphor that he used for what we need to do to improve healthcare quality, I mentioned the translation lag, how long it takes to apply what we know, and the variability in quality. That's easy enough. That's describing the problem. The question is, what's it going to take to solve it, and what other industries might we learn from? And in this case, he looked at a chain restaurant, the Cheesecake Factory. I myself am agnostic about the value of the Cheesecake Factory. I'm not here to endorse them one way or the other, but it raised a lot of very, very important questions. And I think that we will be funding even more research in the future, looking at the development of models, lessons, and methods from other industries, because fixing healthcare in one community or one single institution is fantastic. But the real challenge for us as a nation and for the kind of research that we do is to figure out how we can spread those best practices. So what that means, we think, our annual budget is somewhere in the ballpark of about $420 million. We fund grants and contracts. All the information is available on our website. It also comes to all universities through the NIH guide. Very similar approaches to the National Institutes of Health. In fact, we use their infrastructure for peer review and so forth. But what we recognize increasingly is that we are going to have to be asking more of our researchers. We don't want researchers just partnering and working with and getting input from people who run healthcare organizations or provide care and so forth. We actually want to fund more and more research where those people who are not researchers are actually active partners, because we can't get to the execution plan and making it operational unless that kind of engagement is going on from day one. Now, I hope you find that an exciting idea, that we could get to better care faster. The problem, of course, gets back to how we promote people. Because we tend to promote people in a way that rewards what some people sometimes refer to as salami science, right? Very narrow publications so that you can have a very large pile of publications. This kind of teamwork and working with people who kind of speak a different version of English than you do. They use different terminology, they have different time frames and urgencies. Doesn't necessarily lead to more publications. So thinking about how academic incentives can actually reward this, I think, is going to be very important. And it's also clear that for many of these stakeholders, they absolutely do not want to leak results early or in any way get in the way of researchers publishing. But they get as much out of how the questions are structured in terms of how they can go about improving their jobs. So this kind of engagement is something that's going to be built into our targeted solicitations. Now, so what's this look like? Well, one of the big success stories that we have, also written up by Dr. Gawande in the New Yorker a few years ago, was called the Keystone Project. And this was an effort to reduce serious infections in ICU patients that came about as a result of the kind of special IV line that they got. The mortality rate for these infections is in the ballpark of 25%. And as one leader in critical care told me recently, we always knew about the infections, but we sort of thought they were inevitable. We tried hard, but the infection rates didn't budge. So a team at Hopkins tested a teamwork approach at Johns Hopkins. They then teamed up with partners in the state of Michigan to work with all the hospitals in their ICUs in the state of Michigan. So you can imagine these look very different. Some small rural hospitals, some very, very large academic hospitals. But a similar approach adapted for each unique circumstance. And the partners here were Blue Cross Blue Shield of Michigan and the Michigan Hospital Association. So if a researcher writes to a hospital CEO and says, "You were supposed to send me data, you're late," oftentimes the response is, "I'm getting to it. Life is short and I got a big pile. You're in there." If it's signed by the CEO of the Michigan Blue Cross Blue Shield program, they found that that often rockets it up to the top of the pile. That's what I mean by doing research with stakeholders as partners, and they learned a lot together, and they saw dramatic improvements, dramatic reductions in infections that have been sustained years after the grant funding was over. Most recently, these are called central line associated bloodstream infections. We worked at the American Hospital Association and the Hopkins team, and 1,100 hospitals in 44 different states. And when they implemented this same program, they actually found that it was very, very important, and they got the same kinds of dramatic results. One of the ways we think that this was very effective is that the teams got quarterly feedback. So that's what I mean by engaging the stakeholders, right? They're not writing the papers or, applying for grants, but they are very, very much participating in the process, and the incentive for them was to be able to see how they were doing on a more routine basis. So some specific types of training awards that are on our website right now. One is an infrastructure development program, a so-called R24. One is a mentored career enhancement awards. This is for current researchers to retool and develop new skills in patient-centered outcomes research, so to become more familiar with those methods. But we make research awards in a variety of, using a variety of different K mechanisms, all available on our front page, arc.gov, and there's funding opportunities. And from a question I heard from the last session, people who want to know what we have funded, there's also something called, again, right on the homepage, the Grants Online Database. So you can actually pull up the abstract and sometimes publications of anything that we have funded, either through grants or through contracts. So where I see this all going in the future is that I think more and more of healthcare is going to be about wanting to accelerate the pace at which we apply health research to benefit patients, and also wanting to see evidence that we're doing a good job. How we measure today is not as great as it could be, but it's getting better. And we haven't quite gotten it to the point yet where it's like that feedback that people got in the state of Michigan, right? Where they can actually see the connection between what they're doing every day and the goal they're trying to achieve. That's really the goal we have to reach in measurement through the work that we fund. And we have an obligation, I believe, to do more to ensure that new treatments and research knowledge reach patients as rapidly as possible. And what that means is that basic sciences in this area have to include epidemiology, psychology, communication, social marketing, and so forth. So for many of your institutions, this would be a new kind of research team. And a lot of it is figuring out how to improve the delivery of existing treatments that we use every day. So I end where I began, where our healthcare system is now, where we hope it will be in the future, and how this research can actually help get us there. And I'd be delighted to take any questions.
Thank you, Dr. Clancy. If you have any questions you'd like Dr. Clancy to answer, please send them to federalupdate@missouri.edu. Again, that email address is federalupdate@missouri.edu. Have one question here. Many of the current funding announcements, for example, PA-09-07 ARC Health Services Research Projects R01, have an expiration date of January 2013. Will those be continued for another year? And if so, when will the new announcements be on the website?
I would expect that those new announcements will be up soon, and I would also expect that they will be minor tweaks and enhancements. We have a commitment in the same way that we know that evidence needs to be updated on a regular basis. We think that our funding announcements need to be regularly refreshed, reviewed, and so forth.
Okay, thank you. Again, if you have a question that you'd like Dr. Clancy to answer, please send it to federalupdate@missouri.edu. Can you discuss the role of practitioners in ARC research? Are hospitals and other care providers able to secure grants, or does the research conducted by ARC require traditional researchers to take the lead, like NIH does?
You know, I think we do both. Probably more of the work we fund, traditional researchers take the lead. In fact, I want to say about a dozen years ago, we actually wanted partners to take the lead. And I think we put out a Federal Register notice and tried to communicate to the field, but you know, the only people really paying attention were the researchers, right? So building the space and creating the capacity for these kinds of partnerships, I think is going to remain an important leadership opportunity for researchers for some time to come. Now, over the next 5+ years, would I expect to see more partners? Quite possibly. I'd love to. But, you know, writing a grant application that can pass the muster of external experts in the field and so forth is not something that comes to you immediately or intuitively just because you've got a fantastic question. So I see no shortage of leadership opportunities. I sometimes say that, you know, this kind of work is not rocket science. It's actually harder than rocket science because, you know, this is a team sport in all kinds of ways. So leadership is really key.
Thank you. Again, if you have a question, please send it to federalupdate@missouri.edu. Is ARC funding research that seeks to improve the affordability of simulation equipment or determine the least costly way to use simulation for training and development? For many hospitals, the primary barrier is getting funding to purchase simulation equipment.
I don't believe that we are funding research in that area now, but would certainly be interested in responding to potential proposals or ideas that people have about that. My own impression visiting a number of institutions is that many institutions have found it relatively easy, underline relatively, to fundraise for the equipment. You know, it's kind of cool looking. And you know, you can have a little name plaque underneath it and, you know, show your family or whatever. What's actually possibly harder is actually securing funds and support for faculty time, space, and so forth. But so some of our grants touch on that question but don't address it squarely.
Thank you. Again, if you have a question, please send it to federalupdate@missouri.edu. With the creation of PCORI in the recent healthcare law, will ARC be changing the focus of any of its research, and how do you plan to work with PCORI?
Really great question. So by law, the directors of ARC and NIH are on the board of governors for PCORI, and the law also provides encouragement for PCORI to contract with ARC and NIH to do some work. So that's happened a bit and probably will happen more in the future. And I think it will, if anything, heighten the focus for us on the dissemination and application of findings to improve patient care, because we've got so much to learn there. So I don't think there'll be any shortage of opportunities.
Okay, thank you. A couple of days ago, we had a very sobering presentation on sequestration. Will ARC be affected by sequestration? And if so, can you share with us any of the plans that have been made to address the situation?
Let me just say that our highest hope is that sequestration will not happen, speaking as a member of the administration. And I would also say that I would expect that ARC would get a cut in budget. Technically, because of the way that we are funded. If that happens, then I think our highest priority would be work that focuses on building the evidence base for implementing evidence into practice in a way that makes it operational, what I've been talking about this past hour or so. But again, it is our highest hope that this does not happen.
Thank you. Again, if you would like a question to be addressed to Dr. Clancy, please send it to federalupdate@missouri.edu. Can you tell us a little bit about the review process for proposals, and are faculty eligible to become reviewers on proposals?
Oh, yes. Faculty are absolutely eligible to become reviewers, so if you know of any likely suspects, please email me immediately and I will make sure my colleagues know about it. That's cclancy@ahrq.gov. Again, we use the NIH infrastructure, although we operationalize our own component of that, by which I mean we have impaneled study sections. We have standing study sections who regularly work together to review grants. And we also have what are sometimes called special emphasis panels for targeted solicitations. And we draw from the best and the brightest in the field. And I think if there's any testament to the commitment of the research community to research as an entity, it's the number of people who volunteer considerable and vast amounts of time to reviewing grants. So it is very, very similar to how NIH does it, but with people drawn from skills in healthcare research.
Thank you. If any questions happen to come in a little bit later, I'll make sure that they get to you directly. You can send your questions at any time to federalupdate@missouri.edu. We'll be checking that mailbox. And I'm just going to say thank you very much for being here. And
My pleasure.
Our next speaker will be coming up at the top of the hour.
Terrific. Thank you for the opportunity.